Hello all, this is Miss Gibson. This lecture is going to be over renal replacement therapies. So with renal replacement therapy, this is a therapy that replaces the normal blood filtering function of the kidneys. It is used when the kidneys are not working well, which is called renal failure or acute kidney injury or chronic kidney disease. Intermediate, intermittent hemodialysis is the most common renal replacement therapy, or RRT. This helps remove excess fluid and waste products. It restores acid-base balance, as well as restores electrolyte balance by shutting the patient's blood from the body through a dialyzer back into the circulation. So there's two different ones, intermittent as well as peritoneal. Some reasons that you might start kidney replacement therapy might be fluid volume changes, electrolyte, pH imbalances, might have a buildup of nitrogenous waste. Let's see. Most common hemodialysis is started when uremic symptoms like nausea, vomiting, seizures, or severe bleeding from platelet dysfunction occurs. Drug overdose or even poisoning can lead the patient to need to be dialyzed. So hemodialysis, they're going to have a fistula. The blood let's see. For hemodialysis, the blood comes out of the patient through a flexible tube known as a catheter. The tube is inserted in the vein. Like the kidneys, the filters remove the waste products from the blood. The filter blood then returns to the patient through another catheter. So it's pretty much just like an artificial kidney. Intermittent hemodialysis is delivered over 3 to 6 hours. It uses a machine to mix and monitor dialysate, which is the fluid that cleanses unwanted particles out of the blood. This is delivered 3 to 4 times a week. Their doctor will order that depending on their diagnoses. A temporary hemodialysis lumen or sub-Q device is used until the provider places a more long-term device. There are two common choices. You have a AV fistula and an AV graft. They're formed surgically by connecting artery to vein. The vessel most used is radial or brachial artery or the cephalic in the non-dominant hand. It takes it about 4 months to mature. AV grafts are used when the fistula does not develop. A graft is a man-made tube that is inserted into your arm to connect an artery to a vein. Grafts can usually be used for dialysis within 2 to 6 weeks. You want to avoid taking blood pressure, administering injections, any kind of venipunctures into the arm with the device. After placing the device, after the surgical procedure, you want to elevate the extremity to help with swelling. Always before the patient gets dialyzed, their blood pressure needs to be checked, labs. They're going to weigh before and after the procedure. You're going to provide good patient education on medication that might need to be held, as well as diet and fluid restrictions. So this is just going to go over complications with the AV fistula. Some of the common complications are thrombosis or stenosis, infection, ischemic changes. It can also lead to heart failure. Thrombosis is the most frequent, so anticoagulants are given to prevent that. Most of the infections within the AV fistula or the graft are caused by staph infections. You want to make sure that the skin is cleansed really well. Any ischemic damage, this happens with decreased arterial blood flow to that area below the fistula, which is called Still syndrome. Make sure you look at your resources for that. The signs and symptoms of that Still syndrome are cold, numb fingers to gangrene fingers. Hemodialysis, the intra procedure, which is just prior to, you're going to make sure that there's no clotting, make sure there's no air bubbles in the tubing, make sure the dialysate is at a correct temperature. If you work in a dialysis center, they will give you training on all of this. There's also a special certificate for dialysis nurses. You want to monitor for hypotension, nausea, vomiting. They'll be hooked up to a vital sign machine. You're going to monitor the PTT because they'll probably be on heparin. You want to make sure that you have the reversal for heparin, which is the protamine sulfate. Post-procedure, monitor vital signs, labs. You'll compare the weight and report any significant changes. They will want to avoid any invasive procedures for at least 4 to 6 hours after being dialyzed due to the risk of bleeding. You'll do good checks and monitoring on your hemodialysis site. Check the graft for patency by checking a thrill or a brute. Monitor for signs and symptoms of infection and low blood pressure. Anything that you might have concerns with, you want to make sure you report to the doctor ASAP. PD or peritoneal dialysis. This is installation of hypertonic diacylate solution into the peritoneal cavity with dwell times, and then it drains back out all of the waste products. The peritoneum serves as the filtration membrane. The client should have intact peritoneal membranes without adhesions or infections. If they've had multiple abdominal surgeries, they will probably not be a good candidate. There are 3 steps or 3 parts to this PD. You have your fill, which is when the diacylate is going into the peritoneal cavity. You have your dwell time. This is when the diacylate is remaining inside and filtration is occurring. And then you have your drain time, when the diacylate is being removed from the patient. The PD is slower than hemodialysis. It does require more time. Another problem is it pulls protein in the outflow liquid, which can increase risk for peritoneal injury and discomfort because the protein molecules are so large. Some indications for PD would be treatment of choice for older adults who need dialysis. Some of the advantages, they don't have to take an anticoagulant. So if they have issues with vascular access or have chronic infections, chronic illnesses such as diabetes, heart failure, severe hypertension, the PD can be done, and it can also be done at home, which is more flexible for your patients. This shows you a picture of PD being done at home. This is your CCPD, what one might look like. The CCPD is just a machine. It's a cycler. It just cycles everything. It's usually done at night while you sleep. You will connect your catheter to tubes going to a machine called a cycler. The machine does your exchange for you. It will fill your abdomen with diastylate, wait for the correct dwell time, and then drain. The machine will refill your abdomen with clean diastylate and begin the procedure again. In most cases, the cycler will do 3 to 5 exchanges overnight. This usually takes about 9 hours. Every morning, the machine will fill your abdomen with diastylate for the last time. This time, the diastylate will set in your abdomen for the whole day until you go to bed and begin your nightly CCPD treatment again. The continuous ambulatory PD, this is done by hand using gravity. The exchanges are called manual exchanges because you need to do the exchange yourself. You may do your exchanges anywhere that is clean or dry. So your CCPD is using a machine at night that does all the work. Your CAPD is you doing it. It's more manual with the use of gravity. Make sure you know the difference. Pre-procedural nursing actions, you're going to do a dry weight, vital signs and labs. Afterwards, you will do the same thing. So some patient education that you might give. Instruct patient will feel full when diastylate is dwelling. There may be some discomfort as it is being removed from the body. Continuous ambulatory PD is 7 days a week for 4 to 8 hours. They can continue normal activity. Intra-procedural, of course, monitor vital signs. You're going to check for signs and symptoms of infection. You always want to keep the outflow bag lower than the abdomen. Monitor outflow. What do you think you might want to be concerned with the outflow? Color. You want to make sure that it's clear, light yellow. It should be equal or exceed the amount of diastylate that you put in. If not, you want to make sure your doctor is made aware. Post-procedure, monitor the weight and labs. You're going to do a comparison. Educate the client on signs and symptoms. Take all medications. And then there is a psychosocial aspect to your PD just because it's done 7 days a week. The other is done at bedtime. It takes 9 hours. I don't know about you guys. I hardly ever sleep 9 hours. So it can be quite mentally exhausting, mentally overwhelming. So you might want to have some local support groups, brochures, information handy that you might hand out to your patients if you see that they're struggling with needing some psychosocial support. Of course, we've already kind of talked about this, complications. Make sure you look over this. I'm not really going to go over that because we went over it several times. Signs and symptoms of infection. If you notice any of these, you want to make sure that you notify the kidney specialist or whoever their doc is that is monitoring their dialysis. Kidney transplant, like I said, make sure that you look on your resources. I will have information, extra resources on there about the kidney transplant list. So, Currently, over 100,000 people in the United States are on the National Transplant Waiting List for a donor kidney. So that is really, really sad if you think about that. And like I said, yes, 100,000 is nothing to the billions of people that's on Earth. The sad thing is you don't get that many because there's so many. You don't get many usable kidneys because there's so many health conditions out there. We don't take very good care of ourselves. So just keep that in the back of your mind. So some of your types of donors, you have living, non-heart beating donors, cadaver donors. The non-heart beating donor, this is someone who is declared dead by cardiopulmonary criteria. Cadaver is they've already passed. Clients receiving living related donor kidneys is 90%. They have a 90% kidney graft survival rate. Advantages: some living donor transplants are done between family members who are genetically similar. A better genetic match lessens the risk of rejection. They will be on a lot of anti-rejection medication, though, that has a lot of different side effects. A kidney from a living donor usually functions immediately because the kidney is out of the body for a very short period of time. Some deceased donor kidneys do not function immediately, and as a result, the patient may require dialysis until the kidney starts to function. To donate a kidney, you must be in good physical and mental health. As a general rule, they want you to be at least 18 years or older. You must also have a normal kidney function, no hypertension, cancer, and no infections. Your pre-procedure, of course, they're going to check labs. You'll be on a prophylactic antibiotic. You'll be on immunosuppressive agents like steroids that'll help prevent inflammation as well as rejection. They will get dialyzed 24 hours prior to help increase chance of graft survival. Blood from the live kidney donor is often transfused into the kidney, the client receiving the transplant. Post-procedure, of course, you're going to check vitals, good head-to-toe assessment. You're going to keep up with their I's and O's, assess their urine color, odor, amount, monitor their urinalysis daily for any changes, daily weights, monitor for fluid and electrolyte imbalances like hypovolemia, hypokalemia, monitor for signs of infections, provide a urinary catheter to maintain irrigation to prevent obstruction due to blood clots, give stool softeners, you do not want them straining. And then good patient education on all of those things, which is very, very important. Some complications, which is organ rejection. You have a hyperacute, which occurs 48 hours after the transplant, which can cause some small blood clots to form in the transplanted kidney and occludes vessels. They may have fever, hypertension, pain at the site. For hyperacute rejection, they will have to remove the kidney. So, acute rejection, this may occur anytime from the first week after the transplant up to 3 months. Could also be all the way up to 2 years. An antibody-mediated response starts with inflammation, causes lysis of the donor kidney. Treatment, you're going to get a steroid. They want to increase the dose of the immunosuppressive meds to help with inflammation. Last is chronic rejection. This can take place over many years. Blood vessels, injury from overgrowth of smooth muscle. The blood vessels can cause fiber optic tissue. Treatment for this is you're just going to, conservative, you're going to monitor the kidney functions. There could be ischemia, which is just a delay in the healing time. Renal artery stenosis, just from scarring. Thrombosis, which is just a blood clot. They will be on a blood thinner. And then, of course, infection. Make sure you're providing education on good hand hygiene and how to monitor for signs and symptoms of infection. You will have extra resources on kidney transplant, so make sure that you are utilizing those. If you have any questions or if I have confused you or misspoken, please email me. Have a good day. Thank you.